Welcome everyone to today's webinar, Future Predictions, Preparing for What's at Stake for Healthcare Supply Chain in 2025, sponsored by Simpler. I'm Carly Beam, an assistant editor with Becker's Healthcare. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a Q&A session. You can submit any questions you have throughout the webinar by typing them into the Q&A box on your screen. Today's session will also include a few poll questions. The poll questions will appear on your screen where you currently see the slides. Please click on your screen to respond to the polls as they appear. There are also a few supplementary resources located in the resources section on the right hand of your screen. Feel free to access those to learn more at any point during the webinar. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Lastly, if at any time you don't see your slides moving or you're having trouble with the audio, try to refresh your browser. You can also submit any technical questions into the Q&A box and we'll have someone help you out. It's now my pleasure to turn the floor over to our moderator, Dee Donatelli, Senior Director of Spend Management at Simpler, to begin the presentation. Dee, the floor is yours.
Thank you, Carly. We appreciate that. And hello, everybody. You know, I'm always happy to do these webinars to share knowledge and information across our industry, but today I am more than happy. I am so excited because three great colleagues and professional friends have joined me here today for, I think, what is probably the very first time that we've had all of our associations come together and have a voice united as we move forward in these interesting times. Carly covered all of these things. Hopefully, if you have any questions or concerns with the broadcast, you'll let them know and we'll keep moving on. But today we're going to talk about a variety of different topics, ranging all the way from what you as audience feels is important and the most disturbing or disrupting thing that we have going on. There's so many to choose from. And we're going to respond to some of those, but we also have a talk track that we want to share with you some of our thoughts, not only as individual contributors, but also as associations. So we're excited as we move through the next hour with you, sharing ideas and thoughts on the industry. First of all, just a little infomercial about Simpler. I've been at Simpler for 5 years, as Carly said, as the Senior Director for Spend Management. Some of you may be familiar with the old track manager, MD Byline, Greenlight Medical, Hayes Evidence. So I have the privilege here at Simpler to represent those to our industry. I love our company. I love our company because we are working really, really hard to simplify healthcare operations for all of our providers in the market today, as well as our supplier partners. But more importantly, I think what is exciting is Simpler is launching into a platform orientation. And what we mean by that is bringing all of these solutions together. In supply chain, we work on the administrative leaders of organizations. And as we push our platform forward to CIOs, we are very excited on the future and how we might help make healthcare simpler. With that being said, I am joined today by, as I mentioned, very good friends and colleagues. I am Dee Donatelli. I am going to moderate for today. Unfortunately, Mike Schiller was not able to join us today, kind of a last-minute scheduling change. Many of you know Mike Schiller as the Executive Director for the Association of Healthcare Resource and Materials Management, which is a professional membership group for the American Hospital Association. I've known Mike for years. He's been involved in ARM 4 years and does a great job of providing education and a wonderful resource in our supply chain market via the American Hospital Association. So Mike, we miss you. Thank you for participating. And as we move through the hour, we've had a few prep calls, so we're going to try to represent Mike's point of view as best the rest of us can. Jane, over to you for an introduction.
Sure. Thank you, Dee, and thanks for inviting me. I'm Jane Pleasance, the president for SMI Strategic Marketplace Initiative. Hudson, I think you're next.
Sure. So my name's Hudson Garrett. I serve as the Executive Director and EVP for AVAP, which is the Association for Healthcare Value Analysis Professionals.
And I'm Barbara Strain, the Chairman of the Bellwether League Foundation.
Thank you all very much. We're going to start off, as Carly mentioned, with a quick poll question. Sir, if you would choose which one of these items listed on your screen you feel are the most significant challenges that you're facing or faced last year. And as you do that, and we'll look at the respondees here in a moment, I'll refer to a survey that we did last year. And then in the Resource Center, as Carly mentioned, we have the survey and other resources that Simpler conducted that you might be interested in downloading or learning more about. So let's see how you all are voting. So with those results in, I am not at all surprised. However, what you might find surprising is, in keeping with history, we've always said in supply chain management that we're here for cost savings to help reduce the overall cost for our organizations, right? However, in this past year's survey, we found that we bumped the cost savings. And, you know, part of this in my way of thinking is probably because cost savings is kind of a given, right? That's part of supply chain management. But we bumped up in the survey to say that you all felt like supply chain disruptions were a huge part of the challenges that we are facing moving forward. Actually, 67% in the new survey said that they felt like supply chain challenges will sustain or perhaps even worsen as we move forward through this year. As we know, there's uncertainty with change in our government, the tariffs that we're talking about, ongoing battles that we have on back orders, et cetera. But I would think that contrary to the expectation that we learned something from COVID and that we adapted or changed and eliminated some of these disruptions, it doesn't feel like you, the audience, feels like that's really the case. So we decided that we would think about how are those disruptions impacting particularly patient outcomes, our quest for driving the highest value in our industry. We know that mergers and acquisitions, both on the supplier side as well as the hospital side, are impacting us significantly. But our theme to stress here, I think, for our discussion is let's focus on the patient. So let's go downstream to start with, and then we'll move upstream as we talk throughout the coming hour about what the hot topics are or what comes top of mind, particularly when it is focused on patient outcomes. So patient outcomes are tied with standardizing our processes in supply chain. We've talked about that for years and years and years. And I know, Hudson, you in particular had some very significant thoughts on, how do we bring this back to the patient? So not only Hudson, but let's each one of you give me a minute or so overview on what you think it means to you on supply chain disruptions, and let's just say also coordinated with cost reduction pressures on the patients that we're here to serve. Hudson, you first.
Sure. So, I have two hats, right? Because I'm a provider of a healthcare provider, but I'm also a patient and a consumer. And I go back to an old adage that a colleague at CDC told me many, many years ago when I was young in my career, and it was very simple. He said, Hudson, nobody goes to a hospital or to an ambulatory center, and they don't say they want average or mediocre care. They want perfect care. And I think we can all agree that when we seek healthcare as a consumer of healthcare, that we expect the products, the devices, and frankly, the services that were provided to be as perfect as humanly possible. And so when we think about healthcare supply chain, whether it's resiliency or availability, or frankly, even the person delivering the care, as uniform, as consistent, and as evidence-based as possible. And it really goes back to one simple thing. The use of that device, that product, whether it's something as simple as a Band-Aid or as complex as a Da Vinci, the end of that product or utilization has a patient attached to it, and it has a staff member attached to it. If there's one thing I learned during the pandemic as an infectious disease provider, it's not patient safety anymore. It's really healthcare safety. It's all about the entire team, because we can have all the healthcare providers in the world, but if they're not safe and they don't feel comfortable doing their job, they can't take care of the patient. And so much of supply chain goes back to the work that we do to validate and make sure that safety and efficacy and efficiencies are provided. And I think that's an important element, right? That there is a patient that's connected to the end of that product utilization. And that's such an important element to understand the why.
Absolutely. Jane, over to you. Your thoughts?
Well, first, I obviously agree with Hudson. I think that was a great synopsis of how it gets back to the patient, but I will talk a little bit just for a minute about how I thought of it from a supply chain perspective and my team. You know, every time a clinical person or a caregiver starts looking for supplies and trying to solve supply chain problems, we're taking them away from the bedside of that patient. And so part of what having the right product at the right place at the right time is so true. But also when you look at how many errors can occur when our caregivers and our clinical team are distracted by solving supply chain problems, I find it astounding. And so I think that's the passion, is how's the support that we're giving that ultimately gets time for the caregiver at the bedside.
I love it. You guys know from my nursing background, like Hudson, and I guess all of us, well, Barbara, from your clinical point of view, you probably have similar thoughts. So you want to pile on here?
Sure, I'll pile on. Sort of wearing a couple different hats as a value analysis person, as a supply chain person. I directed those activities for a long time as well. And then my clinical perspective from a laboratory, giving out diagnosis, that sort of thing, and helping with that is the word I came after, and we'll talk about resilience later, but was like agility, is how much are we actually mitigating risk at all times, every day in what we're doing. And so it's co-opting all of those learnings we've had in the past, which helps sort of co-ops with Bellwether, is how do we learn from the past and add those things on that are current practices to sort of mitigate, so it's not reaching that patient level, it's not reaching the patient caregiver level, so that we're able to have this readiness. And I call it the sort of the training all along the way. I remember huddling with the staff that was on the loading dock, and they wanted to know, what in the world did we use these things for? So they wanted to know what our clinical products were, why were they doing what they were doing, and the more they knew, the more we could then have that continuity to help mitigate risk.
Absolutely. And as we were preparing for today, Mike had some points of view that he thought around data standards and tying those back to patient care. But there's still a lot, you know, that we could be doing there. Anybody want to elaborate on that point of view?
Yeah, I might throw in there. I mean, I think CDC is a perfect example where there's been some incongruency regarding some of the public reportable information in the infection world, which is really where my background is lying. And, you know, we've even had some product utilization, we'll just call it workarounds, where publicly reportable information, clinicians got smart and said, well, we only have to report this, so we'll go use a different type of product that we don't have to report the outcomes associated with that. And so CDC has, you know, woken up to the fact that there was some workarounds taking place. And so, you know, I think to your point, Dee, and what Mike had represented in our discussions is, you know, we got to make sure there's an alignment of incentives and reportables, because we want to report the right things, and then we want to take the clinical action necessary to produce the best possible outcomes for our patients. Because, you know, again, a consumer doesn't want to go to a hospital that's just performing according to national average. We ideally want to go to a facility that is, you know, performing best in class. You know, I think that's where we're all going. You know, if we find one of our friends and colleagues that wants to go to an average facility, we probably should give them a talking to, because that's really not the ideal scenario. And there's a product component to that. There's a process component to that. And then I think most importantly, there's a people component to that. And so much of healthcare relies upon our investment in our personnel and reliability that can be built into the supply chain process too.
Absolutely.
So,
go ahead,
can
Barbara,
I talk
please.
about standards for Mike? I would channel my inner Mike by talking about UDI standards, something that ARM and a variety of us have been involved with for over 12, 13 years. And so those are part of the data standards that if we could link everything together appropriately, we could track things better at the patient level, recalls, any product back orders. So data standards, when you're talking about UDI and others, is really a must, not a nice to have.
Absolutely. And, and that's a perfect segue into on the screen, you can see that only 19% of the respondents agreed that non-biased clinical evidence in this case, but a data standard nonetheless, right, is incorporated into making decisions from supply chain's point of view. In addition, only 20% strongly agreed that their physicians and clinicians are supportive in the supply chain activity, which breaks my heart. I'm hoping that we'll climb out of that hole as we move forward. But I know that this is near and dear to all of our hearts as we think through, how do we define the clinical integration, bringing supply chain and the clinical impact to our patients closer together. So I'd ask for you all three to make a quick comment on that topic. Barbara, you want to kick us off on that?
One of the things I think is so important is just what you said, bringing supply chain to nursing, to different departments and things. And you do that through involvement. So you find out there are shared governance nursing practices, and there's committees and clinical practice committees. You can attend a lot of different organizational, within your organization, meetings that currently happen and learn and be part of their agendas, whether it's 5 minutes or 10 minutes, in order to do the right thing and understand more about where they're all coming from and what they're dealing with and how you can remove obstacles to learning about how we can all work together better in a supply chain and value analysis process.
Meeting the customer where they are, no matter what kind of an organization or company you're in, right? Yeah. Jane, what about you? Thoughts on the topic?
One of the most exciting experiences I think I had during my time was partnering in the care redesign process. Yes, can you hear me?
Jane, we got a ton of feedback from you. Let's see what we might need to do to help that. Want to try talking again?
Yeah, is this any better?
Nope, it's no better. Let's move over to Hudson and maybe Carly can help and figure out what's going on. Go on mute and perfect. Hudson, how about you?
Yeah, so, as a clinician, I think there's always been this negative connotation of the word supply chain, right? When you hear the word supply chain, you automatically had this thought of, oh no, they're coming to take my product, my preferred product away. And I think to Barbara's point, there's a different way to look at it, right? And it's almost like, how does supply chain help me continue my continuity of care, deliver with exceptional excellence with the evidence-based practices? And I think part of it is semantics and how we talk about it. It may be an opportunity to really change the way that we message it, but also deeply connect it to the delivery of care. For example, a product is not going to solve all the problems as much as many times we are told by suppliers that that's going to be the case. People and good processes plus a great product will help us solve and sustain good clinical outcomes. And it really does take all three to create a sustainable solution that's going to move the needle. But it's really about how we talk about, I think, the overarching equation that helps. Because clinicians have a lot of challenges. I mean, just getting them to read an email is a challenge. And so if we are going to pick our battles, they have to be priorities that are going to bring them value at the bedside, that's going to bring the patient value, and also make sure that we can deliver upon our promise to our patients, which is exceptional world-class care that's rooted in the evidence. If we do that, I think we'll get higher levels of buy-in that are more deeply rooted in the evidence, and then we more greatly move the needle in a direction that's going to benefit everybody in the equation, which raises the overall value proposition.
I think that was so well said. And I've said for years, as many of us have, a product never solves a problem, right? I love that. So it looks like Jane dropped off to see if she can fix her audio. Hopefully she'll be back and join us again. But let's move on. Hudson, I think we talked about this as a perfect segue to think about what kind of patient outcome metrics can supply chain impact, and how do we think that the supply chain leaders can best impact those metrics? Said another way, we're always in supply chain, we're always tasked with saving money, yet we never use a single product. Or perhaps we don't measure the use of products or the utilization or the value of services in the right ways. I know you've got some good thoughts on that. You want to share those with the audience?
Yeah, and I'll even actually give a quick story. So years ago, I was invited into an intensive care setting to look at a CLABSI, so it's a central line infection issue. And one of the first questions I asked, I said, "Where's the supply chain professional?" And they said, "Well, what do you mean?" They said, "This is an infection control issue." And I said, "No, I understand that, but where's the supply chain professional?" And they said, "Well, we didn't invite them to the meeting." And I said, "Well, wrong answer." I said, "Get them on the phone and get them up here." So, the person came up and team. And I said, "Take me in the supply closet and let's look at all the different components, the kits, the products that you have." Well, lo and behold, they had 13 different central line kits and one ICU. And that creates a lot of clinical variation. I think to your point, Dee, of, well, how do I really assess standardization? How do I assess clinical practice? And then how do I get to an assessment of if I'm delivering good clinical performance? And so when I look at outcome measures, I've got to make sure that I can actually assess it in an apples to apples versus an apples to oranges manner. And so there are good, sort of measures out there. There's the National Healthcare Safety Network, for example, with CDC. There's different core measures that can be ascertained. And again, what I would encourage us to do is not just say, I want to be as good as a national average, but to say, I want to perform as best as possible and get to zero. Think about patient harm. If there's patient harm and it's anything above zero, that is not a good day for any patient, right? Anything above zero is awful. That patient, the family, the experience that they have. And if it's a patient death, that's horrific, right? And so our harm score and our sort of acceptability of that has got to be, completely intolerable. And so I think we can look at outcome measures as sort of a baseline and sort of a performance measure as a KPI. But at the end of the day, are we truly eliminating preventable patient harm? Are we truly eliminating preventable staff harm? If a nurse gets stuck by a needle, that was preventable. What can we do to prevent that? And so I think it's a very complex equation and it requires leadership. And so much of what we're talking about today does require good executive level support too. And when you have that, so many good things are possible. And it also makes sure that the message that's sent across that health system is well, I think, received, but also understood that this is something that's important to our executive level leadership as well.
Well said. Perfect. We'll get back, Jane, in a minute and see. I want to lead on with something else. But Barbara, anything to add to Hudson's points?
To pick up on Hudson's points, he said it really well, is we need to close those gaps in healthcare quality. Because if we're not looking at all of those different outcomes, and it's not just the ones that CMS or others may be looking at, but it could be what's the difference between the best physician doing something and I'm just going to say on the other end of the spectrum, who's spending the more money, but let's put quality metrics to everything that we talk about. So if we're doing consumption of different supplies, you have to associate that with where are they being consumed, how are they being consumed, and why are they being consumed? And Hudson's correct. Supply chain, value analysis, and others need to be present in those discussions because we all have a part of helping to solve each of these pieces all across the industry, whether it's raw materials, manufacturing, suppliers, whatever it is. We all need to do that together, frontwards and backwards.
And I knew that would be your mantra, Barbara, which is why I asked you to speak to that. But Jane, it's a perfect segue into a big initiative that you're working on at SMI, as you shared with us. And I think it's so exciting. And that is, how are you surrounding this with physician engagement? You want to talk a little bit to the audience about that?
Sure. Do I have a better sound now?
It is better. Thank you.
It's better? Okay. I wanted to just reference one quick thing around the clinical integration of supply chain and move into the physician element. But if you as a supply chain leader are engaged in the care redesign process at your organization, that is one of the very best ways to have a clinically integrated supply chain, from the standpoint that when those physicians are all coming together, looking at the entire continuum of care for orthopedics or spine or whoever it is, at the same time you're looking at products from a supply chain perspective, you got all of the clinical quality metrics and everyone around at the same time looking at those products. And it's a super powerful way to move supply chain into what I kind of call the C-suite, which I consider the clinical suite. So let me talk about the physician advisory group for SMI. A passion of mine always has been engaging physicians in decision-making and in supply chain. And when I came to SMI, our members and I also wanted to see, can we bring physicians together who are really engaged and interested in supply chain? So we reached out to our members and gathered together a group of physicians who their passion is about peer-to-peer learning around supply chain in organizations. When we surveyed them, what do you want to come together for? They said, we want to educate other physicians around how you interact with supply chain. What are the things that impact your supply chain in your hospitals? So we developed an education prepared really by our physicians with their input. And we had our first pilot session at Northwell this fall. It was incredibly well received, but the physicians spoke to physicians. You know, it was clearly peer-to-peer, very exciting. On top of that, we created a maturity model, a tool to measure the clinical integration of supply chain, for which those physicians had so much input and review as to how they measured the maturity of your supply chain. And that tool is close to getting finished. There's an element of AI in it, whereby wherever you need to improve in your journey from a clinical integration perspective in your supply chain, the AI element will reach out to good resources that have already sort of been filtered and reviewed for you to pull in information that you can then share with your hospital or with your C-suite around how do we improve and get to the next level of supply chain. So it also has a provider, it has an industry partner element to it to evaluate how clinically integrated they are along with you in your supply chain. So it's exciting, and it's been fun to watch those physicians really get engaged and start interacting with their peers and create a physician masterclass, we call it, for supply chain.
So no
Thanks
pressure,
for asking,
Jane.
Dee.
Well, and no pressure, but you know, that 20% of our respondents who said that physicians and clinicians aren't connected, let's hope that we can increase that by 50, 60, 100% for next year's survey. And the SMI tools are fabulous. A plug for you guys on making those available to everyone across the industry. It's awesome.
That's
Hudson,
right. They are developed for everybody. And I just want to say, for the smallest hospital to the largest. So we try to keep that in mind when we're creating those tools.
Yeah, absolutely. Absolutely. And Hudson, I know as we prepared for this conversation, you talked about particularly how do we measure the impact on patient outcomes? What are some of your expertise and knowledge on areas where we've done a great part of being able, you know, the old saying, we treasure what we measure. What are some ideas or thoughts on how we could do a better job there?
Well, I think first is, you know, the absence of data is not the absence of problem. So, you know, starting with an attitude of awareness, you know, so often I'll talk to clinicians and they'll say, especially surgeons, and they'll say, I don't have that problem. Or I live an infection-free life. And I just laugh internally and say, well, just because you don't know about it, or you don't read your email, or you don't read the report, doesn't mean it doesn't exist. You know, and so you've got to start with an attitude of awareness. And I think number two is, you know, you've got to look at some type of benchmark and say, okay, how am I performing? What am I doing? What am I trying? And if something's not working, that's great. Let's learn from it, and then let's throw it out and move on. You know, small test of change or a key performance indicator that we have, and really diversifying the skill set. that supply chain has. I'm amazed at how many people can't manipulate a basic Excel spreadsheet, for example. Some of the core things like project management or Six Sigma or lean management. These are core elements that an agile healthcare professional and supply chain or healthcare leadership really need to have at least some basic awareness level skill sets for, to be able to function in the complex environment that we operate within. And I think that gives you the flexibility to your point, Tico, from point to point, regardless of what the outcome is you're trying to assess, measure, or implement, and use those interchangeable skill sets regardless of what you're trying to deal with. And I think that's really key, is that agility that's necessary to move from point A to point B.
Appreciate that. Barbara, your thoughts on the topic?
Well, I want to go back to that making informed decisions, because that was one of the sort of standards that we had in our survey, is that you have to have everything come together. And it's not just about the product. It could be equipment, IT, purchase services, anything that's going to surround the whole environment, and then make it better the way it needs to be, not just what you think it to be. And it's everyone coming together, because it's keeping the community well where you live and keeping that high cost care out of the high, acuity type situations in the hospital. But once they're all there, we're all working together to create that overall value. And it starts with that data and what are all those outcomes from the patient all the way out, workforce, any of those things that are really going to help that. So we all need to stay together and build that resiliency in.
Yep, I love it. Absolutely. Jane, any thoughts from you?
I think it's well shared. So I think at the end of the day, what we end up doing has to have, and I think you all said this, if I may have missed it at the very beginning, but the buy-in of the organization in terms of whatever you're doing, bringing people along and be sure they're part of what they help build.
Absolutely. And I think building for the better as we move forward, which is really a pretty nice segue for us to move into kind of the second topic that we had thought would be of interest to our audience, and that is the direct impact of supply chain disruptions. And, the survey said that 56% of supply chain cost setting goals will be higher for the fiscal year in 2025. So really, the whole disruption and cost savings go hand in glove, right? They always have. So let's shift over a little bit and talk where do our thoughts go when we jump right to this topic? Barbara, you want to kick us off on this a little bit?
Well, we can talk a little bit about those disruptions, I think. And I was listening to a webcast just last week where a supply chain person said, I have over 1,200 back orders today. We're almost having a contest lately to see who can say how many back orders I have today. But what they've done is proactively using AI and other IT ways of programming and working with the clinical staff to know, do I need to work on just 40 things today that are going to impact over care the next 3 days? Or do I have to really work on everything? So it's a way of providing that resiliency and risk mitigation we've been talking about, and really looking at things that you're focusing all of your staff and resources into doing what's best by understanding what's really going on in order to do that.
Agreed completely. And the rate of product innovation in the disruption and cost impact that we're having in our industry also came up as we concluded the survey last year. I had the opportunity to speak to a lot of the respondents, and that was one thing that kind of was a recurring theme, is that, and we know as the four of us have been in this industry for a very long time, new technology, poses challenge. Absolutely, do we want to bring new technology into our organizations for the patients that we serve, for the doctors who want to stay on the cutting edge? But the old saying, when does cutting edge become bleeding edge? So I think that that is something that I would like to explore with the three of you a little bit on your thoughts on how do you balance that? Jane, you want to kick us off? Thoughts there?
Sure. You know, one of the things that I always think about, and this goes back to sort of the basics of, you've got to do the blocking and tackling really well and build the trust with your caregivers and your clinical team. And then when you get ready to do the innovative kinds of things, you've got the trust built and the support. Sometimes we love to think, oh, this is really cool and we're going to innovate and we're going to do this. And you've got the clinician still saying, yeah, but you know what, you didn't bring my stuff up and I ran out of power level, if you will, in my cabinet. So that to innovate, I believe you really have to build a good infrastructure and be sure that's solid. And then people are willing to innovate and take risks because they're not thinking every single day of the blocking and tackling. It's just like we turn the light on and everything is there. Yes, we can now think about innovation.
Agreed. Hudson, thoughts?
You know, when you think of this area, I mean, I feel like the fragility, right, of the healthcare supply chain is so critical that it takes one little dam to break, and all hell could break loose. And I think we saw that recently, right, literally, sadly, with the Baxter issue, where despite, you know, great efforts by them to recover, a critical supply chain category became heavily inundated with back orders that, you know, dramatically impacted care. And that tells us that we've got to think very differently about not only redundancy and resiliency, but also just our clinical care processes. And I had a conversation with someone the other day and I said, what did you learn from that event? And they said, well, we figured out that about 66% of our intravenous, you know, bag usage in the ED was really not clinically necessary. And I said, great. I said, that's clinical outcome data. I said, what are you doing about it? And they said, well, we went right back to what we were doing before. And you know, I wanted to pull my hair out and say, well, that doesn't really sound like you utilize that. And this is a large academic center. And I said, get your research folks involved and map this out as to a care process about if you figured out that you didn't need it medically, then make a care flow process that is going to transform it so that we're not overutilizing supplies that we don't need to. The patient is getting exactly what they need. So if, you know, oral hydration is an option, let's move forward with that. But I think it takes those conversations, right, and that dialogue back and forth with supply chain, our clinical partners, our providers, our pharmacists, et cetera, to drive better optimization and frankly to put us in a better position so that if we get into a hole again, we're not operating out of space of fear. And I think another thing to consider too is, you know, how many people in supply chain are professionally trained in incident command? You know, there's free training available from FEMA. I think that's a core thing that every supply chain professional leader, including value analysis and emergency preparedness, you know, we all need to have that training, because if we talk the same language and have the same nomenclature and operate from the same space of here's our shared purpose, I think it will also optimize our responsiveness to some of these issues, whether it's a small back order or a catastrophic disruption. And I think that can help prepare the industry as well as these larger integrated health systems and distribution partners and manufacturers for what may be inevitable that we will continue to face, whether it's natural disasters or something more sinister.
Yep, I love that. So let's stay on this topic for a minute. And Jane, I know we've discussed historically, you have I think, a very unique and strategic vision of partnership perspective. SMI works very closely both with suppliers as well as providers. You know, we've all of us on this call today have preached this for years and years and years. I'm sure we have supplier partners listening in today. Give us some of your thoughts on the evolution of the whole hospital supplier provider relationship moving forward.
Yeah, it's been exciting to see what I think the pandemic and all of the crises we've had in our supply chain have brought about the desire on the part of our industry partners, as we call them at SMI, who want to be engaged with their customers in a different way. So most of us in supply chain, you know, we have our quarterly business reviews and we meet with the sell side. But what's really going on back on the supply chain side of the manufacturer and or the distributor. And so one of our forums, one of our industry partners, global supply chain leader, showed up at the forum. And I was kind of taken back because we hadn't really had them at the table. We'd always wanted to talk to them. But nevertheless, he said, I'm here because I really want to hear. I really want to hear from my customers, and I never get a chance to do that. So we started a supply chain leader advisory group. It is made up of pretty much just supply chain leaders. Providers aren't involved in it very much, but they come and they talk to the group. But what is interesting, we had a presentation on the collaboration between provider and industry partner supply chain, which is peer-to-peer in many ways, at the forum. And lo and behold, the two workshops we had were in the highest demand, which is amazing. We had all of the other usual things, but this was really important. But what was even more interesting was the salespeople were all in the front row of the workshop because they were listening to their supply chain leader talking about how they were dealing with their issues, and the providers were connecting very well. So we have some of our members who are really, I think, paving some new ground here. They want to set up some strategies around how you collaborate between provider and your supply chain leader on the industry side. And we'll see where it goes, but it's kind of a first of its kind.
Well, I'm excited about it because we've talked about it for years. And I know, Hudson, as we were preparing for today, you said something to the effect of, as a clinician, I don't want to see a rep. I want to see a partner. I want to, how does that transformation take place? Because it has to start at that ground or that grassroots level, right? We can't just talk the talk. We got to walk the talk. I think. Yeah,
I mean, time is money, right? I mean, and you've only got a finite amount of time. And if you are bringing an integrated level of value that is going to help accelerate my internal goals, I'm going to make time to see you. If you are understanding what my challenges are, if you understand, for example, that I am, absolutely abysmal with my infection rates, and you can bring me a level of value that I cannot get internally, I would like to see you. If you can provide a peer-to-peer conversation with another facility that has had the same struggles that I have and facilitate that, where my surgeon can talk to your surgeon and frankly not go down the same rabbit hole that we're going down and learn from that, I don't want to talk to you. The challenge is so many sales professionals are approaching it maybe from a quota. I'm here to sell the widget, and we got to move away from that. Because there are some really amazing industry partners, to James' point, that are coming in and saying, tell me about what your priorities are. Tell me what's important to you, and how do you see me being a fit to that? And I think starting with the organization's balanced scorecard that the executive suite and the board of directors is utilizing is a great starting place. A strategic sales professional should understand that and really be able to articulate how do they fit into that, and what is their product, technology, or service. And sometimes it may be, I want to reduce the number of SKUs. I want to take a product that I sell away because you don't need it. It's not relevant, or it's not appropriate for what you're trying to do clinically. And that is an amazing thing when a sales rep comes and tells you that, because no longer are you a sales professional, you're a true integrated industry partner that is doing what's right for our patients. And I think that represents a paradigm shift that's needed.
Absolutely. And that could not be a better segue onto our last topic. If Dee can advance the slides, there we go. That, if we move all the way upstream now to where we talk about the needs in the supply chain themselves, this is where the changes really need to come to play. And I think, as you can see on the slide, 34% of supply chains feel like they're highly strategic in function. Only 28% say that they're very confident that supply chain professionals today have the necessary skill sets. Jane, this comes back to your basic block and tackling. We're running a little close on time, but each of you give me your perspective on what are the challenges and what do you see need to happen in this next year or the coming years that we can really make a true paradigm shift in the way that we partner together to improve the quality of patient care in the United States healthcare system. Whoever wants to start first. Jane, you want to take it?
I'm happy to, sure. This is not a novel idea, but it still does go back to the relationship building that you have with your clinical team and with your caregivers. Because one of the worst experiences that we could all face is when we're in a crisis in supply chain. We're running out of fluids, but we have never established the relationships with our clinical teams. It's very hard to solve problems when you haven't built the trust and the relationships in advance. And sometimes we get really caught up in the teeny tiny transactional component, which is important, or the price we're paying. But the reality is you're going to be able to move your organization along in crisis if you have the trust, you have the relationships already built. Then you're ready to figure out how are you going to deal with a crisis. But if you don't have those in place, especially with the volatility we're seeing right now in our supply chain, it's going to be difficult. So those personal relationships are incredibly important. And that requires some training on the part of our teams too.
And it doesn't happen overnight. You're right. Absolutely. No. Barbara, your thoughts?
My thoughts, picking up on the training, is there's a root cause sort of skills gap within, if you just look at silos of supply chain versus other areas. And you really need to start at that sort of collegiate university level. What Bellwether's been learning through involvement with our various collegiate programs is there's a big gap between what's being taught in these undergraduate, graduate supply chain programs, also involving nursing, med students, and others, is talking about how do you really look at healthcare differently from other sort of supply chain sort of entities. And we have capstone project where we combine those with providers, and they bring all these other skill sets with them. So supply chain really needs to look also at workforces that have project managers, process improvement professionals, and also analysts and a variety of folks. So you're not just looking for how can I hire the next person for the loading dock or whatever. Is we need to expand because they learn all those other skills that we've been talking about. And what is that framework as we go forward?
Perfect. Hudson's, any thoughts?
I've often thought about the term training, and we spend a fortune in healthcare on training. And yet I think we can all agree that we have probably personally interacted with a healthcare provider that was probably trained, but was really incompetent. And so, we've got to move that needle from training to competency, because I think we all want a trained and competent neurosurgeon, a trained and competent nurse, a trained and competent phlebotomist, whoever it may be. And that also is really deeply integrated with supply chain, because so much of that competency is also going to be embedded in the safe and reliable use, and also the correct use of a medical product or device or consumable, whatever it may be. And, from a supply chain perspective, think about your toolkit and your tool belt. Healthcare is changing rapidly every single hour of every day. Do you have everything that's needed on your tool belt to perform? It's almost like Ghostbusters. Are you the person that the executive suite's going to call when there's a problem? And now some of you may say, oh God, I don't want to be the person that they call. So, if you understand supply chain management, great. If you understand value analysis, great. If you understand inventory, great. If you understand, basic business analytics, fantastic. If you understand patient safety and infection control, then you're only further diversifying your value within the organization, and also the things that you can go out and touch. And I think there's a tremendous amount of need for that in healthcare. That utility has to be much more great than it ever has before, where before we had a lot of silos. And I think Barbara said this before, we've always existed in silos. It was this department and that department and the other department. And here's the thing is the patient doesn't get siloed. They may come in through the emergency department, then they go to radiology, then they go to the lab, then they go up to the floor, then they go back somewhere else. And so they don't exist in that silo. And so we've got to make sure that the supply chain world is diverse enough that we can respond that they can respond to the complexities that are thrown at us from healthcare.
And I think that you did a perfect job articulating a whole lot about what AVAP is about, just in that statement that you made. And that was my whole intent of bringing all of us together today, is to share with the audience the collaboration across the associations and groups that we have available to our healthcare industry. We're not all on a different path here. We're all on the same path, leading in the same direction. And each of you do such a wonderful and professional job of representing your organization or your group. Here we can, our audience can get more information about any of these groups, but let's just take a moment. Give me your 30-second elevator pitch on what your organization brings to the industry and how or what information you have that you could share with the audience today. Jane, I'll start with you again.
Sure. Our mission is to bring together thought leaders to create tools, best practices for the industry. We remove the selling element out of that relationship, and we're there really to make a difference and move supply chain forward in a collaborative and partnership way with our trading partners.
Perfect. Jane, Bellwether. Excuse
I'll
me.
be Barbara in Bellwether.
That'd be Barbara and Bellwether. Dee was trying to find the questions to see if we had any questions that we need answered. Go for it. Sorry.
Yeah. So one of the things that the Bellwether does, besides honoring a variety of individuals in various categories across supply chain, we're also the healthcare supply chain historians. So we keep all of the history of what we've done to build the backbone of what we're working on, but we keep infusing it with these modern sort of theories and understanding of what's happening today through all of our various age groups and things that we honor. But we look across providers, suppliers, GPO, distributor, academia, consultants, and media to try to bring a sort of a thread through all of those. And we take off all of those hats to really keep that with the patient and our communities at the center of all we do.
Perfect. Hudson?
So AVAP is multidisciplinary, and really our mission is pretty simple, and it's really directly aligned with the IHI quadruple aim. So it's high quality cost, high quality care, reduction of cost, and really making sure that care is as efficient as possible. And that is really done through a collaboration with end users. So that's at the hospital and healthcare provider level, industry partners. And we've also added other ancillary stakeholders like infection preventionists, the FDA is a member, CDC, the GPOs as an example, because, similar to what Jane mentioned, we can't do it in a vacuum. And it has to be done in a way that's going to really recognize the complexities of healthcare and really create a best practice so that people can model that throughout their institution. I think the continuum of care is going to continue to expand, especially with the modeling of home-based care too. So that's something that we're continuing to focus on as well as AVAP.
I love it. That's great. And having served on the board of ARM as well as past chair of ARM, I can speak for them as a part of the American Hospital Association and the longest standing really organization in this group. Their mission truly is to help educate and network those of us in the supply chain industry and healthcare. Mike Schiller, I'll give it a shout out to him, was a humongous voice during COVID on behalf of all of us when the first time that I had friends in my small community in Kansas say, oh, now I kind of get what you do in supply chain. So ARM is a wonderful resource for everyone from entry level through the strategic visionaries in our industry to pull us together. And here at Simpler, we're excited to provide a platform that can bring many tools and resources together for our customers that we serve across the industry. If you're still on, we'd love it if you would answer a quick question if you'd like to know anything more from any of these organizations, Simpler as well. If you do, certainly we'll contact you. And again, over on the right-hand side of your screen, there's a resource center. Our full survey is there for you to take a look at. I think you might find it interesting to see. I think when I talk to people, respondents from our survey, I think the number one resounding response is, I'm not alone. You know, other people are feeling the same stresses and pressures and experiencing the same kinds of things that I am. And for whatever reason, Dee can't find any questions, but Carly, if there is any resounding question out there that we have just a few minutes that we might be able to respond to. I don't hear anybody coming on. You guys, any of the other people, Hudson, are you playing around with the technology? You see any questions out there?
Yeah, I saw a few, and I think there were a couple themes that I thought maybe we could quickly hit on if we've got just a few minutes. One was around supply chain shortages and really around sole source GPO contracts. You know, I'm actually sitting here in the Premier building right now with two other GPOs, and I think, you know, you're seeing a movement away from sole source contracts for many different reasons, one of which is supply chain continuity. You know, if we look at whether it's Baxter or any of the other big disruptions that we've seen nationwide, that is certainly, I think, created an important dialogue around not only the contracting strategy and the distribution side, but also the clinical side. And I think the clinical side, frankly, needs the biggest amount of work. Because, for example, like if we've learned that 60% of our IV utilization for bags is not necessary, then why are we continuing to move down that pathway? That to me as a clinician screams a red flag. So I think it really requires sort of a multi-tier approach. But I would agree with some of the comments in the chat that, but that being said, you know, if you play the devil's advocate of that from the industry partner perspective, partners are going to make investment when investment can be supported. And so, you know, hospitals, especially for commodity items like intravenous solutions that are, you know, what we'd consider a lower cost item, we're not going to pay a much higher amount for those either to invest in triple redundancies. And so I think there is a middle ground there, right, to say, okay, how do we make sure we've got sort of, you know, a safety stock? How do we sort of have those conversations? And that is where I think an industry partner will emerge versus a vendor. And so whether it's, you know,
Absolutely.
IP bags or whatever it could be, we need to have those conversations with our partners and say, you know, talk to me about your resilience, talk to me about your supply chain redundancy. What happens if there's a catastrophic failure at a plant and location? How quickly can you get other supplies? And frankly, too, I think there's a big role for the federal government from an FDA perspective and ASPR Tracy to say, okay, how do we make sure that there's good supply chain resiliency from a regulatory and a public health perspective too? So there's a lot of opportunity there, but I wanted to at least address that. I thought that was a theme in a couple of questions that came in.
Perfect. And I pulled them up now too. And just so the audience knows, if we didn't get to the Q&A, but we will try to follow up with you. If there's something addressed to one of us specifically, we'll take it offline and circle back. In addition to that, here at Simpler, we have an open house coming up. If you'd like more information on a lot of these topics, I'll be leading that discussion where I'll be excited to share some of our solutions here at Simpler as well. So with that, I want to give a big thank you to my friends, my dear, dear friends, for taking an hour, or actually more than that, because we had some prep time too, etc., for joining us today. The first time I think we've brought all of us together to have a voice in the industry united. As we forge ahead, I hope that that's what we do more of. So thank you all very much for joining, audience as well as panelists, and have a great rest of your day. Thank you all. Bye-bye.
Thank you.